speaker, Professor Ruben Alvaro. He's going to talk about respiratory support stewardship in NICU. As we know, Dr. Ruben Alvaro is the medical director of the neonatal sleep laboratory at the Health Science Center, a former division chief and associate professor of pediatric at University of Manitoba. Dr. Alvaro's neonatal professional activities have encompassed education, research, administration, and clinical care. His main research focus has been on the control of breathing and respiratory care in the fetus and neonate. He has also collaborated in many local and international randomized clinical trials in the area of respiratory medicine and family integrated care in NICU. He has published over 200 original papers, abstracts, review articles, and book chapters, presented over 100 lectures in national and international conferences and seminars. Dr. Ruben Alvarez is going to talk to us in about 25 minutes. Then we will have questions for another 5 minutes.
Well, first of all, I want to thank the organizer of the pediatric conference for inviting me to give this talk today. The topic of my presentation today is titled Respiratory Support Stewardship in NICU. I have no conflict of interest to declare. And I have two major objectives in this presentation. The first one is to describe the initial approach to the management of respiratory distress in newborn infants. And second, to understand how to ventilate newborn infants with RDS. I usually like to use this respiratory score that I find it simple and useful. And it's basically based on 6 items that are very easy to assess. And the score goes from 0 when it's completely normal to 1 when it's moderate to 2 points when it's severe. So when you assess respiratory rate, if it's 40 to 60 is normal, so it's 0. 60 to 80 mildly tachypnic is score 1. And when it's significantly tachypnic, more than 80 breaths per minute, it's considered a 2. When you have no retraction is normal, 0. When you have a mild intercostal, subcostal retraction is 1 point. And when you add to that sternal retraction, gives you a score of 2. In terms of grunting, when you hear grunting only with stimulation is a 1. When you hear the grunting continuously at rest is a score of 2. If you're requiring less than 30% oxygen, but you're not in room air, it's a score of 1. If you're requiring more than 30% oxygen, is a score of 2. And again, when you auscultate, you see if you hear decreased air entry is a 1. When you barely hear any air entry or is absent, is a 2. And also it's important to adjust this score according to the degree of prematurity that you're dealing with. So if a baby is over 34 weeks, again, stays as a 0. If the baby is between 30 and 34 weeks, we'll give you a 1. And if the baby is less than 30 weeks, we'll score as a 2. The maximal score is 12. If you end up with a score of less than 5, consider mild. When you have a score between 5 and 8, is considered moderate. And when you have a score over 8, is considered severe. And we're going to use this score to determine how you're going to manage a baby with RDS. So if you have a baby that is having increased vocal breathing, is tachypnic, breathing more than 60 per minute, and is either on CPAP or oxygen, then you have to assume that the cause of these symptoms is respiratory. Then the first thing you have to do when you have a baby with respiratory problems is to be sure that the baby is able to maintain the oxygen saturation measure as a SpO2 using the right hand, preductal, And the SAT should be maintained between 90 and 95%. So oxygen should be given to aim for that saturation goal. And on top of that, immediately you try to calculate the respiratory score as we described before, if the baby is breathing spontaneously. If the baby is already intubated, the score is not valid anymore. So after you do that, if your score is more than 8, so it's a severe respiratory cause, and the baby is, or if the baby is having apneas that's requiring significant intervention, positive pressure ventilation, so that baby most likely either should be started on CPAP if he's not on CPAP yet, or it should be intubated, especially if the baby is already on CPAP. And the first thing you do when you intubate the baby is for sure checking the position of the endotracheal tube to be sure that you're in the right place. If you do a score and the score is moderate, giving you a score between 5 and 8, or if the score is less than 5 but it's already lasting more than 6 hours, then the next step is to, if the baby is not on CPAP, is to start CPAP, or if the baby is already on CPAP, maybe you should try to increase the pressure and see if that will decrease your respiratory score. So in these two cases, regardless if you are on CPAP or intubated, the baby should have a chest X-ray. Now, if you are a center that have the ability to do lung ultrasound, like we do, sometimes we don't do chest X-ray. We base our findings on only on lung ultrasound. But if not, just a chest X-ray will do. The baby needs to have a blood gas to see if there's any metabolic acidosis or respiratory acidosis. The baby should have an IV, and you should establish a consult with a senior neonatologist. In case the baby is ventilated, you should adjust ventilation, and we're going to discuss later, according to the CO2 level you're obtaining in your blood gas. Now, if you do a score and the score is less than 5, meaning that is very mild and is lasting less than 6 hours, and there is requiring less than 30% oxygen to maintain the SATs in the goal range of 90 to 95%, then together with the group that had more severe RDS, you should try to establish a working diagnosis by looking at the history and the physical examination and all the tests that you had already done before. So when you try to come up with the diagnosis by the history, by the physical examination, by the results of the chest X-ray, then if those results establish that you're dealing with pneumothorax, then you should consider a chest drain and follow up chest X-ray. If the pneumothorax is not a tension pneumothorax and is very, very small, sometimes waiting, it's all you need to do. There's no need to put the hyperoxic, just enough oxygen to maintain the SATs 90 to 95%. And if the baby is already in room air, you don't need to give any oxygen, and just wait and just follow the baby clinically. If the pneumothorax is more severe or the baby is having significant respiratory stress, you should consider needle in the chest or putting a chest tube and do a follow-up X-ray. If the X-ray and the physical examination leads to a diagnosis of RDS or hyaline membrane disease, you should consider giving surfactant. If your diagnosis is more towards transient tachypnea of the newborn or very mild RDS, sometimes all you have to do is continue with your treatment of enough oxygen to maintain the SATs in normal range, plus minus CPAP, and reassess the diagnosis after a few hours. And if the respiratory stress does not resolve after 6 hours, you should reassess your diagnosis and management, see if you need to maybe increase the CPAP or maybe dealing with other conditions that will give you distress. If you're dealing with other conditions like meconial aspiration, pneumonia, PPHN, others, In this case, the treatment is supportive care. Of course, if you're dealing with pneumonia, you have to do a safety workup and start antibiotics. If you're dealing with significant PPHN, you may consider inhale nitric oxide. In all those cases, no matter at what point you are in your treatment, you should always repeat your respiratory scores every 4 to 6 hours. Be sure that you're optimizing oxygenation. Always maintain the SATs between 90 and 95. And if you are intubated or you're on CPAP, always try to optimize respiratory support up or down. Adjust your ventilatory settings according to your blood gases, your oxygen requirement, your clinical condition, and wean or discontinue your support if the baby is getting significantly better. So, regardless of what condition you're dealing with, regardless of the severity of the respiratory stress you're dealing with, the initial management is always adding supportive measurement. And what we mean by supportive measurement, it means that you have to maintain a normal temperature in the baby. You have to maintain normal glucose levels. You need to provide enough fluid intake to maintain fluid homeostasis. Always check the blood pressure. Be sure the baby is well perfused and is maintaining a normal blood pressure and urine output without significant metabolic or lactic acidosis. And if the baby has a possible infection as your differential diagnosis, that baby, of course, should be also on antibiotics. As I said before, maintaining adequate oxygenation is crucial. Not too much, not too little. Again, the goal that I gave you for the saturation of 1995 usually is good for babies over 32 weeks. For babies under 32 weeks, the goal should be slightly different. Usually what we use in the first week of life in babies under 29 weeks, we use 89 to 94. The reason for that is because this baby has high concentration of fetal hemoglobin, and there is a risk for hypoxemia. So we try to aim for slightly higher SATs, 89 to 94, compared to babies that are less than 32 weeks, but they're older than a week of age, or they've been transfused with adult hemoglobin. Those we usually will bring the goal of saturation to 87 to 94, try to minimize the risk of hyperoxemia that will put those babies at risk for ROP and BPD. As I said, always use ideally preductal saturation as your goal. If the baby is grunting and or is requiring high concentration of oxygen, those babies should always be on nasal CPAP. Again, regardless of the diagnosis, it is RDS, that transit acute newborn, meconium aspiration, those babies should be on distending pressure to maintain. So why nasal CPAP is important as a primary mode of treatment of most respiratory problems in newborn babies. Well, first of all, CPAP we know helps to develop an effective FRC. Second, CPAP helps to reduce atelectasis trauma by keeping the alveoli open. Also, we know that CPAP improves oxygenation, decrease airway resistance, splints chest wall and airway, preventing airway obstruction, improve surfactant metabolism, decrease work of breathing, and finally also CPAP promotes regular breathing. Now, the CPAP is more useful, more effective when it's used using short binasal prongs. And the type of CPAP, either ventilator CPAP or bowel CPAP or infant flow CPAP, although they work in different ways, there doesn't seem to be a big difference between different types. So I would recommend that you use whatever CPAP your unit is familiar with and stick with that type of CPAP, because there is really no significant advantage of one versus the other. And finally, the CPAP should always be adjusted to the level of FiO2 that your baby is requiring, the degree of work of breathing, and also the lung volume that you see on chest X-ray. So the CPAP should be adjusted up and down according to all that. Now, after the nasal CPAP, there are also the different modes of non-invasive ventilation that may enhance the effectiveness of CPAP. One is NIPPV, and the other one is nasal high-frequency ventilation. These two modes have been shown slight advantage over just CPAP alone. But again, your unit has to be familiar with this mode before you start implementing them. There has to be a lot of education done. But I will recommend that first maximize the use of nasal CPAP, and as you get very familiar with the CPAP you're using, try to venture into a more advanced mode of non-invasive ventilation like NIPPV or high-frequency nasal ventilation. Now, NIPPV has benefits and has disadvantages. The benefits of NIPPV is that improve gas exchange because it provides some degree of positive pressure ventilation that CPAP cannot provide. Also, as CPAP maintains FRC maybe in slightly more effective way than CPAP alone, helps to decrease work of breathing, and many studies have shown that when it's used properly, it decreases the need for invasive ventilation. Now, the risk of the NIPPV is that may cause a nasal trauma similar to a nasal CPAP, but also may cause air leaks and significant abdominal distension if it's not used properly. The use of nasal high-frequency ventilation is also associated with risk and benefits. The benefits is that helps to decrease apneas. We know also that helps to improve ventilation and bring CO2 down. The risk of a high-frequency nasal ventilation is we don't have, unfortunately, a lot of data in terms of efficacy or safety of this new mode of ventilation through the nose. So it has to be used with caution. And again, either you're talking about efficacy or safety, there's not enough out there to guarantee that this mode of ventilation is safe. Now, if ventilation is an issue besides oxygen requirement, either because your baby is not able to generate enough volume of ventilation to maintain the CO2, that baby should be helped through a bag and mask to help providing enough tidal volume. And if that persists or is not adequate, the baby should be intubated. So what are the indications for intubation and ventilation? Again, this is not written in stones. This is something that we do here in our center. So first of all, if you have severe respiratory stress that is not responding well to either nasal CPAP or NIPPV or nasal high-frequency ventilation, that should be an indication for intubation and ventilation. If you have severe apneas on CPAP, NIPPV, or nasal high-frequency, that should be also an indication for intubation and ventilation. If you suspect that the baby has severe airway obstruction, intubation should also be indicated. If you're on CPAP, NIPPV, or high-frequency nasal ventilation, and the baby is requiring very high oxygen requirement, and here I'm talking about more than 50, 60%, you should consider intubation and ventilation. If you have severe metabolic and or respiratory acidosis, again, that is not responding to other modes of non-invasive ventilation, intubation and ventilation should be considered. And finally, if you have a baby that has a congenital diaphragmatic hernia, that baby should be prophylactically intubated to prevent significant abdominal distension and lung compression. So what are the goals of assisted ventilation? And here we're going to just summarize, give you 3 or 4 pointers that will be generalized to any condition. First of all, no matter what condition you're dealing with, either homogeneous or non-homogeneous lung disease, regardless of the type of invasive ventilation you're using, either conventional, high frequency jet, high frequency oscillator, the goal is always to achieve uniform lung inflation. The next one is try to minimize over and under inflation of the lungs. Always minimize FiO2 because it's one of the most traumatic elements for the lungs, excessive oxygen. And finally, always try to do an early appropriate extubation. Remember, the default is not intubation. The default should always be extubation. Now, how do we reduce overdistension when you're intubated? Well, always try to use volume targeted ventilation with a physiologic tidal volume of 4 to 6 mLs per kilo. The TI, the inspiratory time that you should be using, should be based on the flow waveform to know exactly how long can you go before you start going into signs of air trapping or inadequate inspiratory time. Third, when you see that the FiO2 is falling, always try to reduce the PEEP accordingly. And if that's the right move, then you should always see that your PIP, if you're ventilating with tidal volume guarantee, your PIP should follow. Because if your lung volume remains optimal, you should obtain less PIP with the same tidal volume. However, if you reduce your PEEP and your PIP actually is going up, that means that you lost lung volume, and that's why now your PIP is reading higher with the same tidal volume. Next, always try to avoid inadvertent PEEP, and for that, always look at the flow waveform to be sure that the expiratory limb or the flow waveform reaches baseline before the next inspiration starts. When you are ventilating a baby, it's extremely important that you maintain the infant's spontaneous respiration. For that, try to minimize sedation, and ideally, you should not be using respiratory depressants. These babies don't need much before the respiratory center gets depressed from medication. Also, consider using caffeine, although the use of caffeine may be based on the gestational age of the baby. Definitely, I will recommend using early caffeine in all babies under 32 weeks, especially if they're intubated and ventilated. In babies over 32 weeks, only if they're showing signs of significant periodic breathing anapneas or are unable to be extubated because they're coasting with the ventilator or they're not having a good respiratory drive, should be loaded with caffeine. But otherwise, most of these babies do not need early caffeine. And finally, it's extremely important also to avoid hypocarbia. Now, sometimes the hypocarbia is triggered by the patient itself, maybe because of pain, agitation, but also may be triggered by overventilating the lungs, and that should be avoided at all cost. So the next thing that is important to prevent when you're ventilating a baby is to prevent atelectasis. Atelectotrauma is something that is not good for your patient and may be associated with chronic lung damage. So how do we prevent atelectasis? By using adequate PEEP. I can give you a number for the PEEP. That should be assessed according to the patient you're dealing with, depending on the compliance, depending on the type of lung disease you're dealing with. And that should be assessed again by chest x-ray, lung ultrasound. And but in general, I would say that it would be important to adjust the PEEP, try to aim for a FiO2 that is less than 40%. Okay. So in general, we should increase the PEEP until your FiO2 start dropping below 0.4. The other term that is frequently used is the term of permissive hypercarbia. Increasing ventilation to normalize CO2 risk increasing lung injury for questionable benefit. Means that if you are dealing with a significant lung disease, you cannot expect the CO2 to be 40 or 45. The normal CO2 for severe lung disease may be 50, 55. So you should never try to bring the CO2 down to normal levels when you don't have normal lungs. So also does not mean forcing the CO2 to increase. If you have a baby that is comfortable and has a normal CO2, the X-ray looks good, the FiO2 is low, you should not try to under-ventilate to increase the CO2. That baby may be okay with a CO2 of 40, 45. So it means not chasing the CO2 if the tidal volume is okay, the FiO2 is okay, and the baby is clinically stable. It means being prepared to win if all those factors are okay, even in the face of elevated CO2. Now, I can't emphasize this enough. Early extubation is crucial. Again, the default should be extubation and not intubation. As soon as the baby is intubated, always you should work towards extubation. So removing the tube as fast as appropriate or not intubating if you can avoid it. Self-evident that never being ventilated is better than being ventilated. PPD in general does occur in never intubated babies, but only in mild forms. If you need surfactant, the sooner you can give the surfactant, the better. There are different ways of giving surfactant these days. Here in our center, especially for babies under 32 weeks, we try to use the MIST protocol, or minimally invasive surfactant treatment. For babies over 32 weeks, there is not much difference between Ensure and MIST. So we usually do Ensure, which is intubation, surfactant, and extubation. And finally, the challenge is to identify quickly infants who will need surfactant treatment. And for that, in our center, we use mostly lung ultrasound and FiO2 requirements. If the lung ultrasound has a score of more than 8, and the baby is requiring more than 25% oxygen, that for us is an indication to give surfactant. If you don't have lung ultrasound, you can base your decision on chest X-ray and the level of CPAP and FiO2 to consider the need for surfactant. So in summary, narrow down the possible causes of respiratory distress, quantify respiratory distress using the respiratory scoring, judicious use of oxygen in babies over 32 weeks, aim for preductal SATs between 90 and 95%, early use of nasal CPAP, try to avoid ventilation lung injury, avoiding high pressures, and always, regardless of the condition you're dealing with or the severity, always supporting care is extremely important in terms of controlling temperature, giving fluids, antibiotics, and so on. Thank you so much.
Thank you so much, Professor Alvaro, for this very illustrative presentation. It was a step-by-step management for respiratory distress. If one of the participants or the colleagues would like to ask a question. Well, maybe I ask. As you can see that all I'm attending webinars about the artificial intelligence, medical education, and in the clinical application of this artificial intelligence. So in NICU, do you think that what is called the learning machine used for point care, whether for stratifying the cases of bronchopulmonary dysplasia, or for interpretation of the lung ultrasound, or for advice for the of cases of respiratory distress syndromes, due to the machine would benefit the care of the newborn infant in ICU.
Okay, I don't know. Can you hear me well? Okay, I don't
Yes,
know if you
I
could hear
can.
your question well because you came out, your voice came out very interrupted. So I think you meant to ask me about the test that we need to use to be able to select the proper uh, ventilatory management on a newborn patient. Is that what you were asking me, or
No, I was
sorry?
asking about the role of artificial intelligence again here in NICU in respiratory support.
Okay. Well,
We have heard about the
yeah, I'm not an expert on artificial intelligence, and I think it's something quite new for all of us. And definitely something that is going to come. Is going to be extremely useful in the management of our patients. Um, it's hard to imagine how much the artificial intelligence can help us. For the time being, relying on the test that we are familiar with is extremely important. As I say, in our center, we are relying a lot now on lung ultrasound. I know there are centers that are still not using lung ultrasound. They're still basing on chest X-ray, which is okay. But we find that lung ultrasound, for example, can give you a much more precise indication for diagnosis, and it help you in a much more precise way than chest X-ray. But as I always said, no matter what test you do, clinical experience, a clinical assessment is extremely important. Remember, even if artificial intelligence becomes available, there are a lot of centers in the world that you're going to end up with a baby in the middle of nowhere, and you need to know what to do, and you won't have artificial intelligence everywhere. So be able to learn uh, the clinical implications of a respiratory stress, exactly what to do as a first step, would be extremely important to be able to manage your baby properly. So
Yeah,
maybe Jase has another comment about artificial intelligence.
yeah. Thank you very much, Ruben. May I just jump and add, if you're okay, Dr. Safa, to comment on this question. We developed for the last 4 years some of the online calculators and artificial intelligence related to clinical decision support systems. They are available on our website, newbeats.academy. Newbeats.academy. They are available for free. And some of them, they are related to interpretation of lung ultrasound. So if you do lung ultrasound and you have the score already calculated and you have your the most common or the dominant pattern, either P line or A line, whatever, the online calculator will help you for decision making, will let you know this most probably case of RDS, and you may consider to give surfactant or optimize in lung inflation by increasing the respiratory support. So we'll ask you some question related to also clinical condition, not only lung ultrasound, is the infant on respiratory support or not, if there is worsening hypoxemia or not, and based on that will help you to get into the decision making. And there is another calculator related to ventilation perfusion mismatch. So if you have infant quite sick and on high oxygen support, you can titrate the oxygen in a very simple manner and then watch the impact on saturation when you titrate the FiO2 down. And based on 3 or 4 numbers, you apply that to the calculator, and the calculator non-invasively will give you the estimated ventilation perfusion mismatch. There is another calculator related to assessment of pulmonary hypertension or severe hypoxemia. But in this case, you need to do an echocardiography and also feed the calculator with the with the echocardiography data, and also integrate that with the other hypoxemia or oxygen indices. These calculators, some of them already validated and published, like by our team. Some are still under validation, but they are actually based on already published algorithms. So they are not like 100% novel. They are based on already published algorithm, and we are just converting was published into artificial intelligence calculator or algorithm. And then for sure, before providing that online, we tested on certain patient, and we collect the data, and then some of them already published, some of them is still under publication. Thank you.
Thank you very much. Really, it is very informative. Thank you. Dr. Azam?
I think now we will move to Dr. Asim Lashin.
Yes.
Dr. Sameh, are we ready with Dr. Asim Lashin?
Okay. Just a few seconds.
Okay.
Yes.
Ready now?
Go ahead. Go ahead.
Yeah. Okay. Hello, everybody. So thanks, Dr. Sameh, for your invitation. And now we will have the talk for Dr. Asim Lashin. He is the associate neonatologist in the University of Manitoba, Canada. He's finished his MMBCH in 1993 from Tanta University, and he had his MD degree from Ain Shams University 2003. He got the MRCPCH degree from Ireland 2008, and he had the fellowship of neonatal and perinatal medicine 2018, and the fellowship of the focus of neonatology, point of care of ultrasound 2021. And the topic that he will present is the assessment of crashing infant by the ultrasound. And we'll have 25 minutes, Dr. Asim. Thank you.
Good evening, everyone. I'm Dr. Asim Lashin from University of Manitoba, Canada. I'm going today to discuss the Crash Infant Protocol, or CIP.